You can just stop straight. Yeah. Okay.
Okay.
Yeah, it's done.
Perfect. Yeah.
We're live.
You can start.
Okay.
We're live. We're live.
Perfect. Good evening, friends. Welcome to our Indian Arthroscopy webinar number 114. We talk about posterior arthroscopy of ankle and hindfoot pathologies today. Where are we today? Our guest speaker is Professor Dr. Amendola. Professor Amendola is Professor of Orthopedic Surgery. He's presently at Duke University, North Carolina, US. He's a master in ankle and hindfoot surgery. Shreyash, our friend from Indian Arthroscopy Society, will briefly introduce our guest speaker to all of you so that we are well aware of his great work which he is doing, followed by his presentation. I request you to put your questions on IAS YouTube chat box as well as on the Facebook Live chat box. Shreyash, if you can kindly introduce Professor to all of us.
Thank you, Dr. IPS Oberoi. Hello, everyone, and welcome to this webinar on posterior arthroscopy of the ankle and hindfoot. Where are we today? The use of posterior hindfoot arthroscopy in the treatment of posterior ankle and hindfoot injury has increased rapidly as a means of reducing pain, infection rates, and blood loss post-operatively compared with traditional open procedures. And today we have a world-renowned expert to give us his experience and evidence on this topic, Dr. Annunziato, popularly known as Ned Amendola from North Carolina, USA. He is a professor of orthopedic surgery and vice chairman in the Department of Orthopedic Surgery and the chief for the Division of Sports Medicine at Duke University. He specializes in the management of problems of the lower extremity. He completed his medical degree and his orthopedic residency at the University of Western Ontario in London, Ontario. Thereafter, a fellowship at the University Hospital Western Ontario, University of Verona, Italy, the Crystal Clinic in Akron, Ohio, and took part in AOSSM traveling fellowships. Prior to joining the University of Iowa in 2001, he was the associate professor and chief of orthopedic surgery at the University of Western Ontario University Hospital. He subsequently moved to Duke from the University of Iowa, where he currently is a professor of orthopedic surgery and has held the Kim and John Callaghan Endowed Chairman in Sports Medicine from 2001 to 2005. Throughout his career, he's received numerous awards, peer-reviewed grants, and published more than 200 peer-reviewed articles. He's been an invited lecturer nationally and internationally, as well as authored an extensive number of book chapters and served as editor for 3 textbooks on orthopedic sports medicine and arthroscopy. He's also an active member and a board member of many orthopedic and sports medicine organizations, including the American Board of Orthopedic Surgery, ISACOS, AAOS, and the ANA. So really, the Indian Arthroscopy Society is delighted, and we welcome him. And I would kindly request you to please share your screen and give us your talk on the topic. Thank you.
Okay, can you see my screen?
Yes,
Yeah, perfect.
Okay, well, thank you very much for that very kind introduction, Dr. Gajjar. It's really a pleasure for me to speak to the Indian Arthroscopy Association. I think, the international collaboration and camaraderie, I think, is one of the best parts of orthopedic surgery and sports medicine. And, as being part of AOSSM and part of ISACOS and part of all these societies, that's one of the great things is to meet everybody from around the world. And I think, you in India are really progressing in orthopedics and sports medicine. And this is one small area, arthroscopy of the ankle and the hindfoot. But when you deal with athletes and taking care of athletes, I think if you can minimize morbidity and get them back to play, in a efficient time and get them back to play healthy, I think is very advantageous. So I think arthroscopy around the ankle and particularly the hindfoot, I think is really advanced what we do for athletes, for dancers, for recreational athletes. There's a lot of problems around the hindfoot, and for a long time, there was a lot of hesitancy to put portals in the back of the ankle, particularly in the medial side of the ankle. And we'll go over that a little bit. So I think we're all familiar with ankle arthroscopy. It's been around for a long time. So this is a supine position, going from the front. We used to use distraction a lot more. Now it's generally, without distraction or just using a soft strap like this to take care of generally these problems around the ankle. But again, this was limited because this is the front of the ankle joint, and it's hard to get to pathology at the back of the ankle and even just around the ankle and the subtalar joint. So the image on the left is from Dr. Rick Ferkel's book on arthroscopy. And the image on the left and the right are both from his book. And if you read his first edition of his book, it was really contraindicated to make posteromedial portals. You can see here on the medial side of the Achilles tendon, and trans Achilles and lateral portals were described, but it was really not a good thing. And I think Dr. Ferkel went through 3 editions of his book before he decided that he should include a chapter on prone arthroscopy. So now there's a chapter in his book on prone arthroscopy that I did with one of my fellows. And so, it took a long time for people to accept prone arthroscopy, and particularly using medial portals around the ankle and the hindfoot. So these are the typical portals in the supine position: anterolateral or accessory, anterolateral, anteromedial, accessory medial, and posterolateral. And even the transmalleolar portal was described for OCD lesions in the supine position to try and improve access. And then in the prone position, generally we have the posteromedial portal, posterolateral portal, and then the accessory posterolateral portal, which we'll use and discuss here as well. And so in sports medicine, ankle arthroscopy has evolved, and we use it now for chronic and acute osteochondral injuries, acute and chronic instability. I'm sure you have had the experience of doing arthroscopic assisted ankle stabilization. We can take care of syndesmotic injuries and do arthroscopic evaluation and reduction and fixation of the syndesmosis. Bony impingement has been something that's around for a long time, and removal of loose bodies. So in sports medicine, arthroscopy of the ankle has really evolved into a very important part of sports medicine. And it continues to evolve. Now it's used very frequently in conjunction with the treatment of ankle fractures, and in particular, posterior ankle arthroscopy and subtalar joint arthroscopy is also important for fractures and for arthritis and for impingement, and we'll talk about some of those problems. Tendoscopy has been talked about, and then arthrodesis. In particular, the subtalar joint arthrodesis is a nice joint to fuse, and people get back to a very active lifestyle with arthrodesis of the subtalar joint, and this can all be done arthroscopically in the prone position. So just to go back a little bit, Serge Parisien was the first one to describe subtalar arthroscopy in 1985 using the 3 standard portals. As you can see here, subfibular, a posterior portal posterior to the peroneal tendons, and then an anterior portal in the sinus tarsi. And this was done in the lateral decubitus position to have access to the subtalar joint. This was further elucidated by Carol Fry. And again, this diagram, just to put these are 3 safe portals in front of the sural nerve and behind the superficial peroneal nerve. And with these 3 portals, I think you have good access to the subtalar joint, but I think you do have limited access to the medial aspect of the joint and the posterior subtalar facet. Shreyash added a fourth portal in the lateral position. Here, this posterolateral dorsal portal, which is behind the sural nerve, to have a little bit more access posteriorly. And these two portals, the posterolateral dorsal and the posterolateral ventral portal, could be used to take, for example, an os trigonum out. But again, this was not in the prone position. And then finally, Nick Van Dyke, I was at a meeting with him in 1998 where he presented this case of an FHL impingement, and he added this posteromedial portal, which was a no-no. The way I was trained was not to make any posteromedial portals. And I was at a meeting in Florida, and he showed me this case in 1998, and then he published it in the year 2000, and that's where I started to do prone arthroscopy. So again, the two portals that are generally used are just a few millimeters away from the Achilles tendon. You don't want to be very adjacent to the tendon because I think it does irritate the Achilles tendon, but just go a few millimeters on either side of the tendon. Doing it in the prone position allows you to stay central so you don't drift and move towards the neurovascular bundle. And I think you can do all your surgery in a very safe fashion. So again, everybody's concerned about the neurovascular bundle on the medial side, but the flexor hallucis tendon is really one tendon that you should visualize every time. And as long as you can see the FHL tendon through this posteromedial portal and posterolateral portal, it protects you from injuring the neurovascular bundle. And you can do anything around the subtalar joint and go up into the ankle joint and even in the space behind the subtalar joint in front of the Achilles tendon. So now, with the three previous portals and the posteromedial portal, you really have circumferential access to the subtalar joint and to the ankle joint. So I think you can really, do most of the things you need to do with injuries around the subtalar joint laterally, fractures to the talus, posterior malleolar fractures and impingement, and osteochondral lesions in the posterior half of the ankle and the subtalar joint. So again, this is the position in the prone position. You can use distraction. Charlie Saltzman and I published this paper in 2010. If you're really doing an arthrodesis of the ankle subtalar joint, you can put a small wire through the calcaneus, and you can hold the foot if necessary. But again, I very rarely use this type of distraction. I can use it supine or prone. You can see here the thin wire going through the calcaneus. This is Charlie Saltzman. This is Jeff Junko, was one of our fellows at the time. But you see it increases the space. Here they're doing a preparation of the ankle joint for an arthrodesis. And again, it holds the foot and ankle in a nice position through the whole procedure. If you like to have that, it does help in many situations. So we'll talk about posterior arthroscopy. And again, here you see the picture of the setup of the patient in bolsters. There's nothing special. You can use a tourniquet, a thigh tourniquet. I generally prefer a thigh tourniquet versus a calf tourniquet because I think it just allows a little bit more laxity in the soft tissues around the ankle and subtalar joint. And here's, I generally do it in this position. Here you have the scope in one hand and shaver in the other hand. We're using a strap, just a soft strap around the hind foot. If necessary, you can do some distraction of the ankle joint and even a little bit of the subtalar joint. So this is attached right here, or your assistant can be pulling on that strap if you desire to have some traction. So after I met Nick Van Dyke in Orlando, and he told me about this prone arthroscopy, as usual, you should evaluate things before you do them surgically to make sure that you're happy. So I went back to London, Ontario, and David Sittler was my fellow. Chris Bailey was a resident, and we took 13 cadavers and we made posteromedial and posterolateral portals. So these are cadaver ankles. These are cannulas, arthroscopic cannulas filled with oil to look at the safety of doing these two portals, posteromedial and posterolateral, and look at the neurovascular bundle and measure everything. And so we used MRI and dissection to measure the location of the neurovascular bundle. And then we also looked at how much of the ankle joint you could visualize from the back. So these are the 13 specimens that you can see. About generally 50% of the ankle is accessible from the back in a prone position. So if there's lesions at the back of the ankle, it makes more sense to go from the back rather than to try and go from the front over the curvature of the ankle. So here's one of the specimens, and here's the access that we had up to these markings that we had with cautery, and we measured the surface area that was accessible through the back. Then Pindit Physical was one of my fellows as well, and when I went to Iowa, and we looked at the access of the subtalar joint. So this is the access of the subtalar joint through a posteromedial portal. And you have a little over a quarter more access of the posterior facet on the talus. This is the talus. This is the calcaneus. And you have 20% more access of the calcaneal posterior facet in the prone position using the posteromedial portal. So adding a posteromedial portal gives you more access to the ankle joint and to the subtalar joint. And I think that's why it's useful to have these tools. So to move on more practically, so this is what you see when you, so I start with the subtalar joint first. So this is the subtalar joint here. So I like to make the two portals and look at the subtalar joint. I think Nick Van Dyke did the same thing. So sometimes you have to do a little synovectomy to be able to visualize the subtalar joint. You see here. And the most important thing is after you see the subtalar joint is to visualize the flexor hallucis tendon before doing anything else. So you keep doing a little bit of debriding until you see the FHL tendon. And then once you have all that in view, you can do a little capsular excision over the back of the ankle. And this is the opening into the ankle joint. And so then you can make an opening here and you can see the talus and the tibia, and you can get into the ankle joint. So again, the subtalar joint first, FHL tendon, and then move up into the ankle joint and do what you need to do. So what can you do with a prone position arthroscopy? Well, the most common surgery I do is this FHL irritation in athletes or dancers or swimmers. Often there's an ostrigonum. Posterior ankle impingement at the tibiotalar joint occasionally happens, but not as frequent. Osteochondral lesions of the talus are very common. We'll go over that. For fractures, again, not as common, but I think very useful for undisplaced fractures in the back of the ankle or the posterior malleolus of the tibia. And then subtalar arthrodesis is another common surgery that you can use this approach. So here's an example of a ballet dancer with bilateral posterior impingement. You can see the small ostrigonum at the back. The rest of the foot and ankle structure is normal. And this is typically what you see is normal subtalar joint. You can see the saddle-shaped subtalar joint. There's the ostrigonum where the arrow, the blue arrow, and the impingement. There's the FHL tendon. And you can see the tendon completely going into the foot. So this is a typical view. So that's the FHL tendon. Here I'm just pushing it along and I'm moving the big toe. And here's the ostrigonum. And this is why they get irritation or FHL irritation, because the ostrigonum is slightly mobile. You can see that. It doesn't have to be mobile, but you know, often you get a little bit of motion like that, it causes the irritation. So basically debride around that with the shaver and then use a grasper or use a small sharp osteotome to release it from the talus and then remove it It doesn't have to come out totally in one piece, but often comes out in one piece. So here's another posterior prone arthroscopy. Again, there's posterior impingement. And there's the ostrigonum. It is basically use a shaver to shave soft tissue attachments. There you can see the FHL tendon. Again, you should always have that tendon in view and make sure that you don't go medial to that, and there's no risk to the neurovascular bundle. So again, I think it's a good surgery to do. You just have to be patient, and sometimes you have to do some synovectomy, a little bit of tidying up like this, do some ligamentous attachments and release them from the bony fragment. This was a case actually of very, very prominent. This is a little bit larger than usual. So basically just taking some time to tidy up. Again, this is an unedited video. This is just the arthroscopic procedure. Just wanted to show you it's not, edited videos are always very clean, but here you can see that there's some soft tissues. You don't have a big space to work in. And so just basically loosening up the whole fragment. And then here I got the grasper. Very large. Trying to take it out. And there we go. Anyway, sorry for the unedited video, but there you see the back of the talus where we removed the ostrigonum. There's the FHL tendon. And now we're just going to tidy up the back surface and just make that all nice and clean. Other uses, so that's, FHL impingement, ostrigonum excision. Sometimes with small tarsal coalitions, this was a small posteromedial tarsal coalition. You can see here, this was a young teenage female. And basically, you can excise the coalition. So here's the coalition, and there's the joint. It's not a normal subtalar joint. And here there's the FHL tendon, there's the talus and the calcaneus, and we removed the coalition. So for small coalitions, you can do this using prone arthroscopy as well. I talked to you about the osteochondral lesion. So here's an osteochondral lesion in a 15-year-old where it's on the back half of the talus. You see it's on the posterior 50%. And so instead of going from the front, this makes much more sense to go from the back because it's much better access from the back. So here's the access of the ankle joint from the back. So again, we've gone in and already seen the subtalar joint, and now I'm just doing a little capsular excision on the back of the ankle. So there's the FHL tendon, and here we're going into the ankle joint. So we looked at the subtalar joint, did a little capsular excision, made an opening into the ankle joint. So here's the ankle, and it looks like a normal ankle. There's the fibula, the tibiofibular junction, and there's the osteochondral defect. You can see it's depressed. And you really have good access. Sorry, let's go back here. So we're going to do an excision here and bone marrow stimulation. So basically just outlining the defect. So if it's on the downslope posteriorly, of the talus, I think you should go in the prone position rather than going from the front. I think it'd be very difficult from the front here to get nice view like this and very direct approach to the osteochondral defect. So there's the excision of the defect, and there's the deltoid ligament, medial malleolus, just attaching just below the defect. Subtalar arthrodesis, which I like to call PASTA, posterior arthroscopic subtalar arthrodesis, I think is a good way to fuse the subtalar joint. And here we use 3 portals, the posteromedial, posterolateral, and the accessory posterolateral portal. And so this posteromedial, posterolateral, and this accessory posterolateral is just behind the perineal tendons. And this is what you see in the subtalar joint. We've denuded this is the calcaneus, talus, get down to bleeding bone. We've gone all the way to the sinus tarsi. So the white that you see there is the sinus tarsi. And then, and we'll talk about that in a minute. I just wanted to talk about this endoscopic gastroc recession is something else that I do regularly. Again, it's not, you know, in the prone position, but it is using endoscopy to do something that we used to do open in the back of the leg and back of the ankle. And so, so Pennant Physical was again the person that wanted to investigate this, and really he's the leader in this investigation. And we published this paper of about 320 cases. And again, there's a lot of different techniques for gastroc release. But this is what, you know, we're talking about is basically an endoscopic gastroc release, the C right here, the Shreyash release doing endoscopically. And this was described previously by Christy Giovanni in 2003. And I think this is a much better technique. So this was Di Giovanni's technique, and I think what we do is much better. But we looked at the anatomy. So we're just a little bit more distal here than these 2 portals than Di Giovanni described. So here's what we described here. So we go about 2 to 3 centimeters just below the bulky part of the muscle, gastroc muscle on the medial side, right here, just medial to the gastroc fascia and tendon. And basically go superficial to the gastroc tendon, and then come out the lateral side and just make a little, so here's the probe going from medial to lateral, and basically insert the probe, and we have this slotted cannula. And so if you look towards the skin, you can see you might see the sural nerve, but you turn the slotted cannula towards the fascia. So here's the fascia, and you can move the ankle up and down. You can see the fascia move, and then you use this slightly curved knife blade, and you can cut the fascia, do the Shreyash release under direct vision, and there's the muscle underneath. And it's a very good procedure, and often with foot and ankle surgery, if you're doing an arthrodesis, or you're treating these patients with ankle arthritis, even in the supine position, we'll do an endoscopic gastroc release. And there's a little kit that I use that is sold by Arthrex. It's called the Endo Blade, and we can do this. So this publication was 180 women, 140 men. We followed them up for a year, and we measured their pre and post-operative dorsiflexion, had visual analog scales and outcome scores and morbidity from the surgery. And you can see here, we basically increased their range of motion by about 10 or 11 degrees following this. So I think it's good for patients that have a gastroc contracture or basically have reduced range of motion of the ankle. I think it's a good operation. So we had a 3% incidence of injury to the sural nerve. And again, that was right from the beginning. No wound complications or Achilles problems. And so they basically improved in terms of their function, visual analog score, and foot function scores improved significantly in this group. So if you pick the right patients, I think it's a good operation to do. Again, this is a very straightforward technique. Talk a little bit about fractures. And I think you can use arthroscopy for talar fractures. This, again, I was not the first one to describe this. Charlie Saltzman described this in 1994. But you can do it from the back. So this is a case of a competitive basketball player. You can see the posterior talar fracture. And so here's the visualization from the back. There's the FHL tendon, subtalar joint, talus, calcaneus. And here I'm just going into the fracture. The probe is going into the fracture. So it's quite a significant amount of the posterior facet. And I don't think we could excise that. So we decided to repair that. So here we're just kind of debriding the tissue over the back of the talus. We're visualizing the ankle joint. And then we're using cannulated screws. So we did K-wires to try and stimulate some healing. So we put a bunch of K-wires through the fracture to try and stimulate healing right here. So this was just, creating some vascular channels. And then we took 2 of the K-wires and we put cannulated screws through the back of the talus. So I think in these, fractures, which maybe are not that common, I think this is a good approach to basically visualize and the insertion of the screws with the talar fracture. And there's the FHL tendon, and no impingement from the screws, and there's the screws going through the fragment. And the patient ended up healing that piece and ended up getting back to basketball. Posterior malleolar fractures of the tibia. Again, it's a controversial area. I think most of these don't need to be fixed, but some of them that need to be fixed, I think arthroscopy can be used. So here's a posterior view of a posterior malleolar fracture. And look at the fracture site and the reduction. And again, this has been written about. This is a paper by Dr. Louis looking at use of arthroscopy with ankle fractures. And you can see there's a large number of posterior malleolar fractures, but only about 10% required fixation. And he used arthroscopy to look at the posterior malleolus in the prone position. Kevin Martin was one of my fellows. And here describes a technique using arthroscopic assisted posterior malleolar fracture reduction. So here fix the fibula and then using arthroscopy to help with the posterior malleolar fracture. So you can use arthroscopy in the prone position to help with some fractures around the foot and ankle. And then finally, arthrodesis of the subtalar joint. Again, there's a lot of ways to do a subtalar arthrodesis, including the open technique, making a sinus tarsi incision as shown here. A lot of different incisions described. And I think that's fine, but I think arthroscopically, this is the incision I use open, which is a small incision. And I don't think you see as well as when you do it arthroscopically. So, arthroscopic subtalar arthrodesis has been described by a number of authors. All these other papers, except the one here by Amendola, is done in the lateral decubitus position. We did this in the prone position. And again, this is the position. Use 3 portals. The arthroscope stays in the middle portal, and then we exchange. This is a blunt obturator to put in the joint to distract the joint, and then use a shaver and burr through the other portal. And we exchange those back and forth to clean up the subtalar joint. So here you can see the obturator down here. And basically, it opens up the joint. So here, again, you can see the obturator right here. And then use a shaver and burr to clean up and all the way to the sinus tarsi. So you get a nice view of the subtalar joint. This was a calcaneus fracture that we removed the screws arthroscopically and then the subtalar arthrodesis. It's a nice position to put screws into the subtalar joint because you can bring a mini fluoroscopic machine, and you can visualize very well the positioning of the screws. We published this paper comparing open versus arthroscopic subtalar arthrodesis in 120 patients. 52 were open and 56 were arthroscopic. And when you look at the results, when you look at the two groups, they're very comparable groups. Not much difference between the groups in terms of age, male, female ratio, and so forth. And then you look at the pre and post-op scores, pre and post-op foot alignment, the union rate is very similar, nothing really statistically significant between these two groups. You looked at the type of bone graft, it was a heterogeneous group. Again, there wasn't much difference in what type of bone graft was used. And then when you look at the union rate, maybe there's a little bit shorter time to union in the arthroscopic group than the open group, and a little bit less time to get back to work, but basically very similar results in terms of complications, painful hardware, sural nerve, all these things, very similar between the two groups. So I think open or arthroscopic, I think is fine, but basically showed that the arthroscopic technique was good in terms of relieving pain, improving function. No statistically significant difference to union rate. And then there's a suggestion that the PASTA group had a shorter union time, shorter hospital stay, because we did them as outpatient, and they returned to work and sport activities in a little bit shorter time than the open group. So here's a case of a subtalar arthrodesis. See here, the ankle joint's normal. They have subtalar joint arthritis. It's isolated. There's no significant malalignment, and we did a subtalar arthrodesis. I just wanted to show you this case was a 45-year-old triathlete. You can see the subtalar arthritis, ankle joint is good. And here's the preparation of the joint. I use the screws, or you can use headless screws if you like. I immobilize them for 6 weeks in a cast, 4 weeks in a boot, and then start physical therapy and get back to full activities. And here she is. You can, really can barely see the portals. She's got very good motion of her ankle, and she's really wanted to get back to running activities and doing what she was doing before. And this is at, I think it's around 6 months following surgery. So I think subtalar arthrodesis is a good operation to do arthroscopically assisted, and I think it's best to do in the prone position versus the lateral position. And then finally, with every surgery we do, you should look at complications. So we combined the cases from Utah, where Charlie Saltzman works, and Iowa, and we looked at the complications. Charlie Saltzman likes to use this pin distractor, so these cases were included as well. I generally don't use distraction, so all the cases were included. And here's the indications: OCD, subtalar joint debridement, subtalar fusion, ankle debridement, ankle fusion, partial talectomy, and fixation of a calcaneus, arthroscopically assisted. Extra-articular procedure, the ostrigonum FHL impingement was really the most common surgery. So painful hardware from the fusion, 7 cases, subtalar arthrodesis non-union, and eventually, so the gray is the complications, and then the black, after treatment of the problem, they got better. So Achilles tendon tightness, plantar numbness. So that's the medial calcaneal plantar branch, sometimes gets injured through that posteromedial portal. Sural nerve. So I think there is a small chance of injury. These are 300 cases, low risk, but there's a risk of nerve injury with the surgery. So I think in summary, it's good to see foot and ankle arthroscopies evolving. It's very useful, again, in the proper patients. And I think it does minimize morbidity and early return to activity. And again, you should always, when you do these surgeries, follow your patients so you can learn and keep improving going forward. That's it. Thank you for your attention.
Thank you. Thank you very much. Wonderful. If you can unshare your screen, sir.
Okay.
Yeah, thank you. Shreyash, if you can start some questions.
Yeah, great. Thank you very much for that excellent overview on the topic. So I would just ask you firstly about the role of diagnostic injections around that area. So how often do you do that, and are they useful?
That's a very key question. We use them fairly frequently. I think what you want to decipher with the injection is your diagnosis correct? And secondly, in some of these cases, an injection can be temporarily therapeutic. So for example, if you have, a runner, like I just recently saw one of our pole vaulters who has posterior impingement of the ankle, and he wants to finish the school year, and he doesn't want to have surgery or have anything done until March or April of next year. So we did an injection of the FHL tendon sheath under ultrasound, and we inject local anesthetic and also inject a little bit of steroid. And it got rid of 100% of his pain, the day of the injection. So we know for sure that that's the cause of his problem. And secondly, it will give him some time to relieve the pain. I think it's important for the subtalar joint and the ankle joint. Sometimes you have changes in both joints. Sometimes you have some ankle osteophytes anteriorly, and then you have some subtalar joint changes. I think doing differential injections to see how much each is contributing. And there's many cases where I would do a supine arthroscopy as well. So I put them prone to begin the surgery, look at the subtalar joint, ankle joint, and debride the back of the subtalar joint, and then turn them supine and do an anterior ankle debridement for anterior ankle spurs. So you do both, problems at the same surgery, but I turn the patient from prone to supine.
Right. And for your patients with posterior impingement, we're talking about the FHL and also subsequently peronei, how long would you wait for a non-operative line of treatment before you decide onto surgery?
I think it depends. Most of the time we always do conservative treatment. We always, there's nothing emergent about it. A lot of these patients have been going around with the problem for quite a while. So I don't think it's a fixed amount of time, but generally I would give it, 3 to 4 months to get better with conservative treatment.
Right. But if someone was like a dancer, for example, would you be a little more aggressive, taking into account that he or she might want to go back to that particular activity?
No, yes, exactly. So I think that's why I said it depends. So yeah, I mean, if they can't function at the level that they're functioning, and I think in those cases you should do it as soon as it's convenient.
Okay, excellent. Now, talking about, you clearly mentioned that a lot of the arthroscopy can be done through the posterior medial and lateral portal. In what cases would you go on to doing an Achilles and posterior tibial tendon type of portal? I think one you mentioned was for your subtalar arthrodesis. What other kind of pathologies would you address through accessory portals?
So, so the posterior tibial tendon, or the, I just want to clarify, like tendoscopy of the posterior tibial tendon or tendoscopy of the perineal tendons. So I think if the diagnosis is not complete, again, you asked about the differential injections. As you know, a lot of these athletes sometimes come with chronic problems, and it's hard to figure out, what is causing the problem. So I think if there's still any question in my mind where the pain is coming from, I would do, an accessory portal and around the perineal tendons. So you make a, and look at the perineal tendons and do a tendoscopy to confirm that the tendons are normal rather than, opening up the tendon sheath. And same with the posteromedial side. If they have medial pain, if they've had a medial malleolar fracture, I think often the tibialis posterior tendon is a cause of pain on the medial side or the posteromedial side. So I think in those cases, you'd want to take a look at the tendon. So I would, use a small scope and look in the posterior tibial tendon sheath. So like I've had a couple of teenage athletes with subtalar joint pain, sinus tarsi pain. And so I would, basically do the posterolateral portal and also the sinus tarsi portals, to look at the sinus tarsi and look across the subtalar joint. So most of the time it's when it's undefined, the cause of the problem, you're gonna have to make some accessory portals to visualize.
And that posterior talus fracture, which you showed as one of your cases, for insertion of screw, did you just alternate the portals or did you use a percutaneous portal to just insert your screws?
Percutaneous through the, just make the portal a little bit bigger, but just over the wire. Okay. Percutaneous.
Right. And talking about peroneal retinacular dysfunction and inadequate, fibular groove, I mean, do you address these arthroscopically or they are better off with an open procedure?
I think those are better with an open, and to be honest with you, especially if you're dealing with an athlete, you want to be sure of, a very secure, surgery. So if they have perineal tendon instability, I think you can do the tendoscopy to visualize and, do your diagnostic evaluation. But I think if you're going to do surgery, it's better to do it's right there. It's just, under the skin, small incision, and you can take care of all the pathology. If they have a low-lying muscle, they have some synovitis, they have a split tear in the tendon, you can repair it, and then you can deepen the groove at the same time. I know you can do it. It's technically feasible, but you like to have a very warm feeling at the end of the surgery that this is solid. We can begin early therapy. You don't have to keep them immobilized for a long time.
Yeah, absolutely. And final question from me is about the Haglunds. What about the role of, hind posterior arthroscopy for this problem?
For Haglunds?
Yes.
So, as you know, most of the time Haglund syndrome is in the older patient and they have tendinopathy. They have tendon degeneration, they have some calcification right in the middle of the tendon. I think in those cases, I think you should do open. So I do a midline incision and split the tendon, debride the tendon, remove the Haglund's prominence, and then repair the tendon down to the bone. In the young patient, so we just did a 23, 24-year-old girl who's a runner with a insertional Achilles, but her MRI, the Achilles in those young patients is normal. The tendon is normal. All they have is a bursitis, retrocalcaneal bursitis, and the Haglunds. So I do those endoscopically. So in the younger patient with normal tendon with the Haglunds, I do those endoscopically, and I make those portals are made, just in a similar location, just a little bit lower down, closer to the calcaneus tuberosity. And I should have showed that, but we just did that this past week. We did a girl from Louisville. So again, it's not as common in the younger patient. I would persist with non-operative treatment for Haglunds for a long time in the younger patient. But if they persist and they have normal tendon, then I would do the endoscopic calcaneoplasty.
Okay, great. Thank you. IPS?
Two questions on chat box on me. One is, what is the role of these ACP injections and tendinitis around the ankle? So how often would you do autologous conditioned plasma, something like a PRP?
Well, we use it as well in our, I take care of all the teams here at our university. And then I see a lot of athletes from the other universities around this area. And then I see some, I'm a consultant for the NBA Players Association. So I see quite a few soft tissue problems around the foot and ankle. And so we do use PRP. So we use, again, in the US, I don't know how it is there, it's not approved by insurance. So it's all out of pocket. So in these situations in our university, athletes and the professional athletes, they can pay for it. So, I think there's no side effects or problems. So we tend to use it for, so plantar fasciitis is a common one that we would do under ultrasound. I think for ankle, so if somebody say has had an ankle arthroscopy and debridement, and they continue to have some discomfort and they still have a pretty good, a good joint, we would use in that situation maybe to stimulate some healing. We use it for subtalar joint synovitis and irritation. We've used it for perineal tendinitis with no tears. So most of the soft tissue problems around, we do use it in this group of patients. Again, in the normal patients that come to the clinic and you say, well, you have to pay for, we don't charge that much. We charge the kit to do and plus the injection, it comes out to about $1,500. So it's not too expensive. I don't know, what's it cost there?
So that's around 30,000. It's around $600 here in India.
Yeah.
Around 600. Another question here is there a role of a soft tissue endoscopy in plantar fascia, plantar fasciitis, plantar fascia release?
I think there is. Yeah, I should have. So I have a partner here who does ultrasound. He's a primary care physician trained in ultrasound and ultrasound guided surgery. And so before doing a plantar fascia release, so releasing the medial band of the plantar fascia, and I do that endoscopic in recalcitrant cases. And again, I would urge everybody to try conservative treatment for, at least 6 months in those cases. But I use this, Dr. Bogus is one of my partners here, does under ultrasound guided treatment, goes at the insertion of the plantar fascia and does a little bit of debridement, just the attachment site of the plantar fascia. And then right after that injects PRP. So that's the first line treatment for that group of patients. And I do that for Achilles, mid-substance Achilles tendinitis. We do ultrasound guided, basically needling on the ventral side of the Achilles. Just go in under ultrasound and just go with the needle up and down, try and stimulate some healing of the Achilles tendon.
Another question is, you see a lot of these patients with tendinitis around ankle. Is there a role of shockwave therapy, something like a lithotripsy, which these guys who do the kidney stones, they're using the shockwaves. So is there a role of these shockwaves for conservative therapy of such kind of tendinitis around ankle, especially recalcitrant one?
Well, I think, I'm familiar with that technique. I was involved in a study that's published in Foot and Ankle, a multi-center study on use of that for plantar fasciitis.
Yeah.
And in that study, we did a blinded study for the patients. We did a tarsal tunnel nerve block, so they had numbness on the foot, and then the patients didn't know if they got the lithotripsy or not. And the results were 70 or 71% successful with with that shockwave therapy.
Mm-hmm.
it wasn't, it wasn't 100%, 70%, but I think it makes some sense. I don't know what the evidence is. We don't use it here. And there's not many people around this area that use that. But I think most of these tendinopathies are not healing because the healing response is poor. So if you can stimulate the healing response, I think it's probably a good thing. So that's why I think the shockwave therapy basically causes a mild injury to the area to stimulate a healing response. So there's probably some science to it.
Sure. Swarnendu, you have any questions? Hi.
Samanta.
Yeah. But the thing is that I joined late because I was busy in the hospital. But most of the places in India, sometimes people I have seen that they put steroid in the plantar fasciitis and also in the retrocalcaneal space, or also in front of the chronic tendinitis and all these Haglands. Do you ever recommend, or you don't recommend at all the steroid around your plantar fascia or the recalcitrant sort of tendinitis in the TA tendinitis?
I definitely would say no to steroid in the retrocalcaneal bursa. I think steroid around the Achilles tendon is not good. I think it's just too much of a risk. And so for retrocalcaneal bursitis or around the Achilles tendon, I tend to use an injection of Toradol, just not steroid, just Toradol, which is an anti-inflammatory, and it doesn't have the detrimental effects of steroid. In the plantar fascia, yes, I think I think steroid is good. I think if you can weaken the plantar fascia and you get a little bit of micro tearing of the plantar fascia at the attachment, I think it's probably good therapeutic treatment.
Okay. Thank you.
Thank you. Ned, one question on the chat box is about ArthroCare quantum bands. So ArthroCare was a company which actually popularized quantum kind of a console with a band which is specifically for tendinitis, and they would actually do with that radio frequency thing to stimulate healing. So is there any experience of these? A lot of surgeons in India actually got and purchased these quantum bands from ArthroCare company, but probably their results are not so great. So
IPS is much like the tennis elbow, right?
Yeah. So they expose it and then that's just to the radio
multiple
frequency.
punctures. Yes, correct. Yeah.
Just wanted his opinion. Has he used it or?
No, I haven't used it. I can't give you any advice on that.
Perfect.
Great. I think we're right on time.
Absolutely.
Yeah, great. So really on behalf of the Indian Arthroscopy Society and myself, we are very grateful for you to take time off and participate in this webinar today. And we wish you good health, and hopefully we'll connect at some point in the future.
Well, thank you very much
for joining in. It indeed was a wonderful presentation and something which is quite new to a lot of members of Indian Arthroscopy Society. We are still new into ankle and hindfoot, and I think the type of work which you showed, especially the hindfoot pathologies, were really eye-opening. So nice of you to have joined, and thank you very much for making us wiser today evening. Thank you.
Thank you.
Oh, thank you
very much. Thank you.
Thank you very much. It was a pleasure, and I hope all your members get something out of it. So thank you.
Absolutely. Thank you.
Have a great